favorite city, and on, I think, invitation of my favorite person in rheumatology, in PSR, Babar. Thank you for always being humble, and at the same time, always doing something, always like leading from the front. Thank you for organizing this wonderful event. So today's objectives, I have just kept that I would be talking about difficult to manage, and then would be trying to highlight what exactly is the difference between when you say difficult to manage to difficult to treat, and then talking about something which is a refractory disease. And I would be doing this through case scenarios. And what are the drivers which are actually behind this cohort and this phenotype, which is now called difficult to manage disease? And then, yes, we all need to sit together and develop individualized precision medicine where the role is, or where we would say that considering our own real world situation scenarios to come up with solutions to contributors to develop who are driving factors for difficult to manage spondyloarthritis. I'm wondering, are there any postgraduate residents from internal medicine, any junior colleagues sitting here, house officers? If there is even one or two, I would really like that this disease, which you still call ankylosing spondylitis, the nomenclature was changed many years back to axial spondyloarthritis. And the disease which we call now non-radiographic is a disease which is an early disease in which there are changes only on the MRI and there are none actually on the X-ray. So the ASS classification in 2010 told us about this non-radiographic, and this spectrum of disease from a non-radiographic to a radiographic stage may take years for a patient to develop. Not everyone would go from that stage to a stage which is like a bamboo spine. So every patient will be following a different course, and there are different trajectories. And then there are factors which are associated with poor prognosis, like high CRP, HLA-B27 positivity, male gender. Generally, these are the things which we know are linked with the progression over 10 years to up to 24% of patients. So 1 in every 4 ending up with a disease in which somebody can get crippled, disabled, is not a good disease to have. And when we look at the evolution of armamentarium in spondyloarthritis, like RA, so we have like not only just NSAIDs, anti-TNF, we have IL-17 inhibitors as well. This is a unique pathway in which the psoriasis guys and spondyloarthritis patients, they are only the ones who are getting benefit with it. And then the JAK inhibitors, which were initially the drugs which are approved for rheumatoid arthritis. And now, since 2021, we know that the tofacitinib got approval for axial spondyloarthritis, and later on, upadacitinib as well. And then there is a drug which is bimekizumab, which is both IL-17A and F inhibitor. So this is also in the market, but not yet available in Pakistan. When we look at the guidelines, the ASUS and the EULAR recommendations, they tell you to start again conventional, non-steroidal anti-inflammatory drugs and not conventional DMARDs in patients with pure axial spondyloarthritis. For patients who have peripheral arthritis, yes, you can try sulfasalazine, methotrexate, and can give intra-articular injections, but there is no role for oral steroids. Once patient has failed 2 NSAID courses over a period of 4 weeks and still has a high STAS CRP, which is more than 2.1, this patient becomes candidate for, in a presence of expert opinion by rheumatologist, for a TNF inhibitor or IL-17 inhibitor. So where is the place for JAK inhibitors? JAK inhibitors are generally considered to be second-line targeted therapies after a biologic has one biologic has been failed. But in our situation where we have influx of JAK inhibitors in the market, it's like being flooded, and they are as cheap as now almost double the cost of leflunomide. Somebody was telling me leflunomide also cost around 65 rupees a tablet, and perhaps you might have a jack which is available in 100 rupee per tablet. So what to do in that situation? So I'm really intrigued to look at the slides of Dr. Faris Yahya. So if you do not treat these patients who have active inflammation going on. Active inflammation itself is going to drive inflammatory pathways, which are going to trigger cardiovascular events. They are going to trigger dyslipidemia. So if you have one option, so are we really reaching a point where we can think of repositioning of JAK inhibitors in our diseases, which is a topic which is really very controversial, and still the jury is out on it. My first case is a 35-year young male. He came to me from UAE. He was wheelchair bound. He came from the flight and was directly came from the airport, was very much depressed, tense. He has a job, he has a career. There was insurance there. He was diagnosed as having radiographic axial spondyloarthritis, and he was started on non-steroidal anti-inflammatory drugs and later on adalimumab, but he was not feeling any better. He's a tall guy of almost my height, and with the BMI of around 38, 39. So married for 3-4 years, one kid, no reason for him to get depression. Otherwise, very well settled in his career. And on examination, he had marked tenderness, especially in the mid-thoracic region. And his ESR and the CRP were skyrocket. So considering someone who's in adalimumab, what would come to your mind? So patient being treated with a monoclonal anti-TNF, anyone? So fellow year one, anyone sitting here? Carry spine. So this is what exactly he, before coming to me, actually, he had been seen by a spinal surgeon, and he was started on empirical ATT, and this was his MRI like. And I think, Harun, you would agree with me. So this is nothing uncommon we see in patients with the axial spondyloarthritis. These are Anderson-Leon. They can be mistakenly, if they are just 1, 2, or skip kind of lesions, even without any paraspinal soft tissue component, they are misread by many radiologists as Carey spine. So this is what exactly happened in this kind of a discitis, which actually was not TB, but he was being treated for that. And obviously his adalimumab was also stopped, and he was really in a very bad condition. So this was him. So in the office, Cushingoid as well, because he was started on prednisone as well. Without even having any evidence of tuberculosis and any evidence of spinal cord compression. So, but the generic prescription which generally any spinal TB got, and he was on 3 to 4 weeks, he was on prednisone as well, having still a very high BASTI, high CRP, the high BASMI scores, which is BASMI is a meteorological index, which tells that he has not very high, so but modestly, his spinal mobility was also affected a lot. I started him on secukinumab. Worry about restarting adalimumab was also in back of my mind. I gave him a good loading dose and started him on 300 milligram every 4 weeks, but he didn't do well. He was seen again in 6 weeks and in 12 weeks when he was still that bad, not able to start his activities of daily living, not able to go back, still having depressed, and a lot of us now issues to access as well, because in UAE he had an insurance, and now he has actually no savings left in the last 3 months, and everything has gone into secukinumab, I believe. And he was on duloxetine and pregabalin as well. I referred to physical therapist, involved psychiatrist, and started him on upadacitinib. In 4 weeks, again, not much improvement. Considering his BMI and nothing left in my armamentarium, I thought about escalating the dose to 30 milligram. So I thought just give him a shot. He doesn't have any cardiovascular risk factors. And we know that there are reports of using tofacitinib, I will be talking about in a while. And he was up and about in, because there is some analgesic effects with JAK inhibitors as well. And there is, in fact...
Prabal ji, Sajid aa gaye?
the medicines, and in 4 weeks, he was feeling a lot better. So this was a study which was published last year, a small case series, which shows that escalation in the dose of tofacitinib in patients who were not having meaningful
करीम,
clinical improvement,
बेटे
which is
आप
like
मेरे साथ लगेंगे?
more than improvement in
सभी
score of
भैया का
2
रूम
in
साफ
stress.
करेंगे। प्रभु जी, ये ऊपर
We
भिजवा दूं
were
दोनों?
put on a high dose of tofacitinib in an open arm, and in
हाँ,
this target strategy in this population, this strategy worked well in this small group of patients. But still not, these are not in the guidelines, such recommendations. This is the ASAS difficult to manage axial spondyloarthritis definition, which came last year. And we know that all three parameters have to be met. But we know if somebody is being treated as per the guidelines of ASAS and the ULAR and has been failure to biologic or targeted synthetic DMARDs of having different mode of action, at least two or more. So patient along with them if have insufficient control of signs and symptoms of axial spondyloarthritis, which is defined by high disease activity, STAS, high CRP. This is so very important, and active inflammation on MRI, or rapid spinal progression, which is generally we have a MSAS score, and if there is a rapid over like 6 or 1 year, there is a rapid progression, or if the present signs and symptoms which are perceived problematic by the rheumatologist or the patient. This is so very important that patient has to fulfill all these criteria. This is more stringent definition. The initial definition, difficult to treat, came from what we generally had from rheumatoid arthritis, but this stringent definition, so we have a few studies which are done in the last 2-3 years with the definition which was the previous one, and which showed that this is a French cohort, and the frequency of difficult to treat axial spondyloarthritis in their cohort was 1 in 5. This was more common in women, and with an odds ratio of around 1.93 in bivariate analysis and in multivariate of 1.79, with peripheral symptoms in psoriasis and accompanying depression. So these comorbidities like depression has to kept in mind, but luckily the other comorbidity like hypertension, dyslipidemia, diabetes, even uveitis or smoking, to some extent, yes, smoking as well, 1.47. They were not like significantly associated as compared to these four. Exploring this same data in a Dutch clinical practice registry, it showed that female gender again is one thing which is consistently being shown difficult to treat population, and we need to explore what exactly are the factors, driving factors. Is it hormonal? Is it like a different phenotype, or is this accompanying fibromyalgia or central sensitization? And the current smoking actually was shown also to be one variable associated with difficult to treat disease and ongoing psoriasis as well, with a very high odds ratio of 2.8 in multivariate analysis. And the smoking also had a very high odds ratio. I am now moving to my second case. She's a 33 years female, married. She's para 3. Her last child was born 1 year back. It was a spontaneous vaginal delivery. She's a home maker. She's obese with a BMI of 32. She's hurting all over. She has low mood. She has recent weight gain. She's fatigued all the time. Uh, the, the primary physician was treating her on the lines of fibromyalgia, but on inquiry, she had classical inflammatory back pain as per ASAS scale and in the Berlin criteria. This was her X-ray like, which was like all normal SI joints. So her BASTI was very high, her S-test CRP was high, and she had a positive HLA-B27. CRP was just modestly elevated. Her films of MRI were not there, but has been reported to have bone marrow edema on the sacral and on the iliac part as well in few of the films. But she was fulfilling, according to that MRI report, criteria for ASS diagnostic criteria for MRI. Etanercept was started, but didn't help her improved her BESTI and S-test for next 3 months. She was switched to tofacitinib later in June, continued on duloxetine. She had a clinic visit just a couple of weeks back. She was still hurting all over with a back pain score of 7. So the question is now to the audience, to the house, are we really dealing with difficult to treat or difficult to manage? It's really very difficult to dissect inflammatory versus non-inflammatory pain in females, especially. And this is what exactly I was also perplexed. What's going on? What should I be doing in this? So if this is non-inflammatory, then answer would be different. So I, I would also say that one also need to question the diagnosis. HLA-B27 can be positive in up to 4.5 to 8%. We are not having like a nationwide study, but different geographic ethnic backgrounds in Pakistan, it is anywhere between 4.5 to 8%. And it is a normal gene to have. 8% of the population can have. Am I really dealing with this disease? Because we know that postpartum, so this MRI was done within 6 months. And this kind of a patient would say yes to everything. You would ask a leading question with ASAS, yes, I have pain at night. Yes, I feel stiff in the morning. And you will have all the criteria. So you can label her and you can treat her. It's all your show. But what exactly I was wondering was, are we dealing with difficult to treat or difficult to manage? Or have I really been able to nail the diagnosis? So the correct diagnosis, I have kept it in the center. That is so very important when your patient is not improving. Always revisit. So think of adherence to the treatment. Your patient might not be taking medications. You don't do drug levels. So there are other comorbidities going on, fibromyalgia. So fear of side effects at times lead to non-adherence. Dose adjustment, optimization of the dose, which is actually required at times because of a very high BMI. This happened in our first patient. And I think that was the case. He was 6'2" and he had a very high BMI, and 15 milligram of pardacetinib might not be the right dose for him. And these are all, when you talk about a refractory patient, you really need to rule out all these possibilities before labeling someone difficult to treat, which is now a better term is refractory disease. So such patients are the ones who are having intrinsic factors, their disease factors. And the patients who have difficult to manage disease, generally in this umbrella term, this is a subset of this whole big part, difficult to manage. This is what the Spartan group actually has suggested. If you have a confirmed diagnosis of expa, if symptoms are such that your patient now requires biologic DMARD, and if somebody has failed 2 biologic DMARDs or TST-MARDs with different mechanism of action, this is difficult to manage SPA. And then if STAS is more than 2.1, with objective evidence of inflammation, by saying this, I mean, they are saying elevated CRP or bone marrow edema visible on MRI, then this is difficult to treat or treatment refractory expa. In that situation, you can suppress inflammation. You can do more to suppress. You can even think of escalating the dose, optimizing. You can think of even adding something on top of that. But in this group, difficult to manage, you need to involve other colleagues, physical therapists, and you need to involve psychologists, multidisciplinary team, support group, and that is how generally I treat my patients with expa. This is what exactly the factors which are driving to contribute to D2M disease. Active inflammation, that is refractory. Structural and mechanical changes. Somebody who already has developed a bamboo spine, hips are gone, cannot walk, has such limitation in performing activities of daily living, no matter whatever you do. So that patient is not going to improve. In that case, it would fall into a category of difficult to manage, not like difficult to treat or refractory treatment, because you know that this is not the time now to suppress inflammation. The damage already has occurred. And psychological comorbidities, central pain sensitization. We all know that there are gender differences when this comes to frequency of depression, anxiety in patients with all rheumatic diseases. Men have a different way of handling coping mechanism, and women have a different. And it's not like that the burden of disease altogether in female gender is just because of depression and anxiety. They have high bust-I scores, but our these scores, which we know now that there is a gross gender difference, are these scores really looking at these parameters of non-inflammatory pain? Are they just not being the ones who we were trained to look at a pain which was nociceptive? A nociceptive pain is a one which is because of injury or inflammation. We are not very good at treating nociplastic pain, so which is like kind of a pain all over, fibromyalgia pain, and the neuropathic pain. Yes, that also happens in these patients. So current disease parameters of the scores for expa are insufficient to make a differentiation between inflammatory versus non-inflammatory pain. Central sensitization is one of the confounding factor in the evaluation of treatment responses. And patients with expa should be reevaluated in terms of presence of nociplastic pain before making biological decisions. So this is a study which was published 2 years back in RMD, and it showed that even patients who have done well with a S-DAS of less than 2.1, which is low disease activity achieved, still 27% of these patients actually had a nociplastic pain going on. And this is what exactly happens when you use some new tool for your slide making, and it really becomes tricky. In a presence of low CRP, minimal inflammation, S-TAS of less than 2.1, symptoms which are ongoing, and then functional limitations, and especially I would put structural damage as well. What not to do is to biologic therapy escalation or switching from one class to another. And what to do in that situation is actually to establish a multidisciplinary team. So always remember, structural damage, it's not going to get better. So if somebody needs a hip replacement, you have to refer a colleague, orthopedic, for a hip replacement, and that would really change the outlook of your patient. And role of multidisciplinary team of physiatrists, psychologists, social workers. And this is what exactly we were able to do with the help support of Arthritis Care Foundation. This is a prospective cohort of patients with axial spondyloarthritis, was established 2019. We have presented the data at different forums, EPLAR as well as ACR, looking at treat to target strategy in patients with axial spondyloarthritis. And we had almost the same, like as generally in the cohort, majority are they are radiographic. 84% of the patients have, which is ankylosing spondylitis, and then very minority of these patients are actually non-radiographic. This is what exactly happens in a setting which is rheumatology, a tertiary care setting. Patients come to us late. There is a diagnostic delay of 5.7 plus minus 6.9 years in these patients. When we looked at a number of patients who are on biologic or TST MARDs, so it was around 46% in our cohort who were being treated considering treat to target strategy. And out of this now, JAK inhibitors, 39%, they are actually on JAK. And then the second most is IL-17 and anti-TNF, 27.2%. And it is not just your preference. This is actually the issues of access in countries like ours, in which you actually end up prescribing a medication which might not be the first line, but that is the most viable option for you. And when you look at this difficult to treat definition when applied to my cohort, so around 14.7% of the patients, they were the ones who have actually failed at least two of the biologic and TST MARDs. And men actually 13.7 versus 21.1% females. So females are more likely to have difficult to treat disease even in our population. This is what exactly a dual therapy combination strategies in different spondyloarthritis other than expa is happening now, and the data is not yet randomized control trials. This is just anecdotal data from the retrospective studies or real world studies. And the future agenda is, yes, obviously, the combination which is working well for IBD, guselkumab, an IL-23 inhibitor, along with the TNF inhibitor, golimumab, has been published. And there is some reports that combining IL-17 or IL-23 with JAK inhibitors may be beneficial for a certain number of patients. This is my take home for you, that if you really find these things in your patients at the outset, let them know that you are very likely to be the ones who would have to be very tricky patients to treat with, because you might be the ones who would have difficult to treat, difficult to manage disease. Always address comorbidities. If you would not have a weight reduction strategies, dietitian on board, not have a physical therapist, a psychologist in your team, so you would not be able to give best services, the standard care to your patients. And I'm leaving you with these messages, which is just what I have already discussed. Thank you for your patience. And I would really like to acknowledge my mentors, my colleagues, my fellows from the department, from Arthritis Care Foundation. And thank you for having me this morning. Assalamu alaikum.